Decreasing 30-day readmissions for decompensated heart failure by early referral for outpatient IV diuresis by Jamoia Walker. My committee members included my DNP chair, Dr. Snell, as well as my community member, Dr. Christine Insing. Over 6.2 million Americans have heart failure, and it accounts for over 13% of deaths each year. Many of those with heart failure also have comorbidities that contribute to progression of heart disease and multiple organ failure, leading to readmissions. Despite the gains in medication and device therapies such as cardiomem devices, decompensated heart failure remains a leading cause of hospitalizations, with over 1 million occurring every year. 80% of the cost of care for heart failure is directly related to hospitalizations, and this currently amounts to over $39 billion a year and expected to nearly double to over $63 billion by the year 2030. Heart failure hospitalizations are resource intensive. Often multiple procedures such as coronary angiograms and imaging such as echocardiograms need to be performed during the admission. Readmission rates for heart failure are 26% of the total readmission rates, making it a leading cause of readmissions among all medical surgical diseases. This prompted provisions in the Affordable Care Act to penalize facilities with elevated 30-day readmissions for chronic diseases such as heart failure. And this is because many of the heart failure readmissions are avoidable. It's estimated that 1 in 4 patients with heart failure be readmitted within 30 days. With every readmission, there's also a negative impact on the patient's morbidity and mortality. Literature has shown that administration of IV diuretic in an outpatient setting is a safe and effective way to treat heart failure in those who are mildly decompensated and hemodynamically stable, leading to a resolution of symptoms with continued weight loss and delayed readmission by up to 90 days. Delays in readmission are associated with improved health outcomes and significant cost savings for both the facility and the patient. This scholarly project aimed to decrease readmissions for 30 days for chronic heart failure patients by implementing a policy change, and it showed that early referral for IV diuretic therapy led to a reduction in readmissions and cost savings associated. When searching for literature related to the scholarly project, keywords and phrases were used. The search was completed via Maryville University's libraries collection of nursing databases and the National Institute of Health library. From these libraries, over 150 databases were accessed. To narrow the analysis, the following limiters were used: published between 2012 and 2022, peer-reviewed journal articles in full text in the English language, and Boolean operators such as AND. These limiters enabled the finding of more specific articles of focus. The initial search included the phrase decreasing 30-day readmissions for decompensated heart failure, and it netted a return of a little over 1,600 articles after all the limiters were applied. This initial search was vast and returned articles covering the prevalence of heart failure, 30-day readmissions, outpatient IV diuresis, and causes of readmission. Adjusting the key phrases and subject tab allowed for more articles to be selected for this review. The chosen articles included peer reviews, meta-analysis, retrospective cohort studies. Several of these studies focus on using APRNs as leaders in the outpatient diuresis clinic and demonstrated as a positive and safe and feasible way to prevent 30-day readmissions. The remaining articles focus on causes of readmissions and the effect of readmissions on the morbidity and mortality of heart failure patients and the facilities that care for them, as well as the current heart failure treatment modalities. The 30 articles were then grouped accordingly using the following 4 themes: risk factors or causes of readmission, prevalence of readmission and effects on healthcare costs, readmissions that increase patient morbidity and mortality, and improving patient outcomes by administering IV diuretics in the outpatient setting. These themes allowed for a wealth of literature to be narrowed in such a manner to help focus and guide the scholarly project. With this review, the literature will support the need for a practice change, leading to the creation of an algorithm for early referral for IV diuresis in the outpatient setting. This scholarly project aimed to implement a practice change that improves patient outcomes and better utilizes resources within a facility. The theory that best fits this is Pettigrew and Whipp's content, context, and process model strategic change. The idea is that these three dimensions work together with content or the what, which focuses on the objectives, purpose, and goals. Process is the how or the implementation, and content is the where, which includes the internal and external factors. So for a change to be successful, these factors must interact together simultaneously. Now applying this theory to the project. Content or the objectives or purpose is to decrease heart failure readmissions. The need for this is evidenced by the heart failure readmissions being the leading cause of all hospitalizations. Content splits the external and internal factors. Here, the external factors are those that affect the patient, with repeat readmissions increasing morbidity and mortality rates and often worsening any comorbidities, as well as the cost of care. And this is supported by the fact that 1 in 4 heart failure patients would be readmitted within 30 days. The internal factors include the costs associated with caring for the patient at the facility level, which could be upwards to $85,000 per admission, depending on the plan of care. With the implementation of a practice change, the impact will be felt at both the external and internal level. Lastly are the processes or the methods or actions that were implemented to make a change happen. With any practice change, a policy must be created and disseminated to the stakeholders for implementation. In this case, the IV diuresis algorithm was created for the purpose to guide providers in their decision-making process on whether to refer a patient for IV diuresis. The focus of the study was to create a practice change. In order to do this, the impact of the practice change would need to be quantified. It was determined that creating a qualitative exploratory design via prospective and retrospective review of the electronic medical records and the facility's heart failure admission database would allow for participants to be identified based on criteria. So some of the inclusion criteria was that the participants had to be over 18. They need to have a diagnosis of heart failure that can either be listed as chronic systolic heart failure, acute on chronic heart failure, diastolic heart failure. Their admission would have needed to occur between June 22nd and August 28th of 2023. There would have been documentation that they were seen in the heart failure clinic within 7 to 10 days of discharge. And then at that visit, there would have had to been a gain of at least 5 pounds or more. There should also have been documentation that guideline-directed medical therapy was either initiated at discharge, titrated at discharge, or continued at discharge. Exclusion criteria included such things as no heart failure diagnosis in their chart, or if they had an allergy to furosemide. A sequential inclusion and exclusion process continued until a participant panel of 75 participants was achieved. A power analysis was calculated using a statistical package for a social sciences program utilizing alpha of 0.05 as the significance criteria. Now, with the inclusion and exclusion criteria, it helped to ensure that only those who were hemodynamically stable were selected, while keeping the process as randomized as possible. Limiting the study to 75 participants ensured that statistical significance was achieved while not risking it by making the sample size too large. So the sample was a composite of the inclusion criteria, which again included adults that were over the age of 18, admitted between June 22nd and August 28th, had a diagnosis during their admission of heart failure, and were seen within 7 to 10 days of the discharge. The racial makeup of the group, 90% of the group were Caucasian, 10% were from other ethnic groups. The participants were grouped by the plan of care on the data collection sheet. Descriptive statistics used were meeting the parameters for referral, referred for IV diuresis, those who were not referred with up titration of oral diuretics, those who were not referred as they were euvolemic or stable, and also whether or not a readmission took place. These groups allowed for the comparison of those who were readmitted and if a referral for IV diuresis was a factor or not, such as those who were found to be euvolemic post-discharge visit or had their oral diuretics up titrated. A statistician was consulted in February of 2023 to determine the appropriate statistical test for this project. Descriptive statistics would allow for summarization of the data collected into variables in a logical and meaningful manner. Nominal and ordinal data were collected for this project and applied to chi-square analysis to determine if early IV diuresis is related to decreased readmission rates. Nominal data, which is the lowest level of data collected, or simply puts it into categories. The categories utilized include referral, stable at discharge, and up titration. Ordinal data is the ranking and measurement that places the data in order without distributing the values. Ordinal data allowed for the collection of analysis of readmission rates among the different categories. Data collected from the retrospective chart review was tabulated on the data collection sheet utilizing descriptive statistics. A bar graph was then able to be created from the data. A pylori analysis resulted in a suggested sample of 75 participants. So let's look at some of the results of the study. So after applying the inclusion and exclusion criteria from this first bar graph here, we see that about half of the participants met criteria for referral. But despite half of them meeting criteria for referral, less than half of those who were actually referred for IV diuresis. In this third bar graph here, we see that the most common plan of care at the post-discharge follow-up visit was up titration of oral diuretics. Now, when comparing the different options that providers had at that follow-up visit, in this bottom graph here, you will see that those who were referred for IV diuresis were admitted at a lower rate compared to those who had their oral diuretics up titrated and those who were found to be stable or euvolemic at the post-discharge follow-up visit. Thus, it can be inferred from this project that early referral for IV diuresis is effective in reducing readmissions for those with decompensated heart failure. Despite the project's success in demonstrating that early IV diuresis reduces readmissions, limitations were noted. A major limitation centered on provider discretion. To reduce the appearance of coercion, providers were given the diuresis algorithm at the beginning of the project, and it was recommended that they use it to guide decision-making. From the data, about half of the participants met criteria for referral for IV diuresis. Only half of this group were actually referred. Throughout the study, participants had first right of refusal. With a survey after the data collection period via the EMR, it was discovered that though some participants opted to decline referral in favor of up titration of their oral diuretics, most of those not referred were at the provider's discretion. Reasons given by providers included the need for more familiarity with the consult and referral process, despite instructions being provided, the belief that IV diuresis was excessive based on clinical presentation of the patient, and an unwillingness to stray from commonly accepted clinical practice guidelines. Without the appearance of coercion, these barriers could have been overcome if providers were reminded to use the diuretic algorithm as a way to assess any apprehension. Despite the limitation leading to an unexpected low percentage of referrals, the study's findings are consistent with similar studies conducted after patients underwent IV diuresis at later stages in their treatment. A post-implementation barrier was also identified, and this had to do with the length of the project. The implementation period for the scholarly project was intended to be 4 months, with a 1-month retrospective chart review. However, this was decreased to 2 months due to delays in obtaining Maryville IRB. Thus, the time to review EMRs and the facility's heart failure database was limited and likely impacted the participant sample. Though 75 participants were able to be selected in the 2-month implementation period, there were fewer heart failure admissions at the facility during this time. With a longer time, the participant panel would likely result in a more varied study. If the project were repeated, it would be done over a more extended period of time to attain a varied sample base and likely more referrals for IV diuresis. Thus, increasing the time frame would ensure more participants would be able to be included in the intervention. Based on the findings, the 30-day readmission rate among the 75 participants was 32%. This is higher than the national average of 26%. An inference can be made that a factor in the overall higher readmission was provider discretion with the referral process, as only 17% of the 49% who met criteria for IV diuresis were referred. Therefore, to improve patient outcome, more provider education regarding the referral process as well as the effectiveness and safety of outpatient IV diuresis compared to current treatment modalities is needed. Those referred for IV diuresis had a lower readmission rate compared to those who were either stable or had their oral diuretics up-titrated at the post-discharge follow-up visit. As heart failure remains a leading cause of readmissions with estimated costs expected to increase to over $69 billion by the year 2030, a practice change such as early IV diuresis can help to lower readmissions, thus decreasing costs. Patients readmitted for heart failure have a higher cardiovascular and non-cardiovascular morbidity and mortality tied to every readmission. In most cases, readmissions for decompensated heart failure are preventable. A significant strength within the study is the heart failure clinic setup, which is comprised of RNs, a clinical nurse specialist for education, PAs, NPs, a pharmacist, and a heart failure cardiologist, where the standard of care at this clinic is to see patients within 7 to 10 days of discharge. And there is also the ability to refer for same-day outpatient IV diuresis at the infusion clinic. Such a setup allows for prompt intervention in the outpatient setting, as most symptoms of decompensated heart failure occur within 1 week of admission. Most of the 20 participants referred for IV diuresis were seen within 3 days of referral. Another strength of the study is the IV diuresis algorithm, which allows for all providers to follow the same decision-making process, thus ensuring that only those who met criteria were referred. Successful implementation of a practice change on a larger scale would involve cardiology clinics having the ability to set up their practice in a similar fashion, with access to outpatient infusion clinic as the most essential. Implications of this study to future practice and future research lies in its success, as the findings are consistent with similar studies that took place after months of oral diuretic titration and readmissions. The project has found that IV diuresis is effective when administered in a mildly decompensated patient within 1 week of discharge and can prevent readmissions. As there is a direct correlation between readmission and worsening health outcomes, devising a way to lower readmissions will have a positive impact on both the patient and the cost of care, allowing for better allocation of resources, which equates to lower costs for both the facilities and the patients. But not every facility will have the ability to refer for outpatient IV diuresis. Therefore, alternatives to early intervention must be considered. One such alternative is subcutaneous furosemide injections. These can be administered by either the patient and a nurse or home health nurse at home. Therapeutic levels are reached within 30 minutes of administration, and achieving therapeutic levels so quickly allows for better bioavailability, which is equivalent to 80 milligram IV furosemide, and it lasts for 6 hours. The availability of furosemide in this manner sub-Q is more expensive, so further research opportunities exist in determining if extended therapeutic availability correlates to reducing readmissions and improved patient outcomes. In conclusion, as this QR project was successful in lowering readmissions when compared to those who had their oral diuretics up-titrated or were thought to be stable at the follow-up visit. But if done differently, I would prolong the implementation period to allow providers to be assessed to identify for any apprehension in order to increase referral rates. With this project, findings will be presented to the department with the intention on implementing a practice change of early IV diuresis referral. From the DNP process as a whole, I've been encouraged to continue driving change where plans are already in place to come up with ways to treat chronic angina. The steps in drafting this DNP project has helped me to narrow down the topic as well as anticipate any potential challenges or barriers that may exist. Now, time for any questions. Thank you for listening to my presentation.